The following podcast is part of a certified educational activity titled Experts vs. AI, Who is Better at Monitoring and Treating MASLD and MASH? Access the entire activity and complete the post-test at peerview.com/RNX860. Downloadable slides and practice aids are also available.
Hello, everybody. Welcome to the CME session titled Experts vs. AI, Who's Better at Monitoring and Treating MASLD and MASH. I'm Rohit Lumba from University of California, San Diego, Professor of Medicine and Chief of Division of Gastroenterology and Hepatology there. With me, I have my co-chair, Dr. Alina Allen. She's Associate Professor of Medicine, also Director of the MASLD Clinic and Research Center at Mayo Clinic, Rochester, Minnesota. These are the objectives for this activity: describe the disease pathway and mechanisms that define MASLD, MASH as serious, chronic, and progressive metabolic disease, discuss the role of GLP-1 as a therapeutic target in MASLD, MASH, and other components of metabolic syndrome, explore the use of non-invasive tests and biomarkers to monitor MASLD and MASH disease progression, and decide how to initiate early guideline-driven management with available and emerging pharmacotherapies to delay MASLD, MASH progression, and improve outcomes in our patients. An updated nomenclature is there, and we all know that NAFLD is now called MASLD. Individuals who had the milder form of non-alcoholic fatty liver disease called NAFL are now called as MASL, metabolic dysfunction-associated steatotic liver. There's a definition change: steatosis in the absence of other etiologies, for example, moderate or significant alcohol use and viral hepatitis. That was previously in NAFLD, and now we require presence of steatosis or fat on either imaging or biopsy in the presence of at least one metabolic risk factor. If you look at the process by which we came up to this new nomenclature, it required multiple iterations, working together as a group with multiple societies and stakeholders. We had multiple rounds of consensus or Q&A that led to formation of this name or nomenclature for steatotic liver disease. I think it's important, and it is now fully adapted for use by both AASLD as well as other societies within the United States and European Association for Study of Liver Disease. The key features related to MASLD is that alcohol intake above 20 grams or 30 grams in men, along with features of metabolic syndrome, are associated with a new entity called combined metabolic dysfunction-associated steatotic liver disease with alcohol, or MetALD. Those who consume excessively, which is 60 grams for men and 50 or higher for women, they are classified as alcohol-associated liver disease. So this is the broader classification for steatotic liver disease. To the left, we have MASLD and the progressive form of MASLD called MASH, which is characterized by ballooning degeneration and fibrosis. In the middle, we have a spectrum of patients who have both components of metabolic disease as well as alcohol use, and then those with alcohol-associated liver disease with higher consumption of alcohol. We have also identified a specific group of individuals who may have drug-induced liver injury leading to steatosis in the liver, or monogenic diseases, as well as cryptogenic SLD where no cause is identified. What is metabolic dysfunction-associated steatotic liver disease? MASLD occurs in individuals who have at least 5% of hepatocytes or on imaging infiltrated with steatosis in individuals who consume little or no alcohol and have at least one metabolic risk factor. We see patients who have the progressive form called MASH with histology characterized by steatosis, as well as ballooning degeneration, inflammation, and chicken wire fibrosis, and that can lead to progressive liver disease leading to cirrhosis and hepatocellular carcinoma. For diagnosis of MASLD, The first event is identification of steatosis, either on biopsy or on imaging, followed by looking for cardiometabolic risk factor. If your patient has cardiometabolic risk factor, then they'll be classified. These would be the criteria in adults to the left and pediatric to the left. Majority of our patients who have steatotic liver disease do meet these criteria, and the predominant cause of steatotic liver disease continues to be MASLD. Now, if your patient to the left meets the criteria with metabolic syndrome, then and does not consume excessive alcohol, those will be classified as MASLD. If they consume alcohol that is more than what you would classify as MASLD, that is 20 grams for women and 30 grams for men, be classified as MET ALD, or higher, more than 60 would be ALD. MASLD epidemiology and prevalence is rising. Dr. Ellen and others have done a lot of work in this area. We think about a third of adults in the United States and worldwide may have MASLD. Prevalence of NASH ranges from 12 to 14%, depending on the epidemiologic study and depending on the disease state. It's also very common in patients with type 2 diabetes. 70% of patients with type 2 diabetes have fatty liver or MASLD. And about 10 to 15% have clinically significant disease, which is characterized by stage 2 or higher fibrosis. Therefore, it's an important issue, particularly in those who have type 2 diabetes and obesity. This is the natural history of MASLD. We think about 60 to 80 million Americans have MASLD, and about 15 to 20 million may have the progressive form of MASLD called MASH. Individuals with NASH can progress and develop fibrosis. We think about 13 to 16 million Americans may have stage 1 to 3 fibrosis. What is the fibrosis progression rate in NASH? We think it's about 1 stage per 7 years. 20% of patients who have fibrosis progression may be fast progressors, and they could progress to cirrhosis within 5 to 10 years. Once you develop stage 3, 20% of patients with stage 3 could go on to develop cirrhosis in the next 2 to 3 years. Once you develop cirrhosis, that's when liver-related morbidity and mortality rises exponentially. Number 1 cause of mortality in patients with MASH is cardiovascular disease, number 2 is cancer, and number 3 is liver disease. In US population, general population, liver disease is 12th leading cause of mortality. In patients with MASH, it jumps to the 3rd leading cause of mortality. In patients who have cirrhosis, the risk of hepatocellular carcinoma in MASLD is about 1.5 to 2%. And once you develop cirrhosis, 30 to 40% of these individuals may die due to liver disease over the next 5 to 10 years. And therefore, MASLD is now becoming an important etiology for liver transplantation, both in men and women. MASLD is part of a systemic disease with strong association with multiple components of metabolic syndrome. These include hypertension, coronary artery disease. In heart, we see diastolic dysfunction, heart failure. In liver, we document and see significant insulin resistance. Fat deposition in liver leads to hepatic insulin resistance. And in some patients, they can go on to progress to NASH, fibrosis, cirrhosis, and hepatocellular carcinoma. In pancreas, we see beta cell dysfunction, and majority of our patients may also tend to have type 2 diabetes, particularly in the setting of advanced fibrosis. We also see adipose tissue insulin resistance, inflammation, and also expansion of adipose tissue volume in the setting of weight gain and obesity. Patients with MASLD are also at increased risk for chronic kidney disease. So there's a clear metabolic stress in our patients, particularly with overnutrition and also with concomitant alcohol use. This leads to an inflammatory milieu that leads to progressive liver injury and activation of hepatic stellate cells, leading to fibrogenesis in our patients with obesity, type 2 diabetes, and insulin resistance, and progressive liver disease. This is looking at patients who have type 2 diabetes and risk for MASLD, at-risk MASH, and cirrhosis based upon an epidemiologic study conducted at UC San Diego. To the left, I'm showing you prevalence of MASLD is 70%, at-risk MASH is about 15%, and we also see cirrhosis in our patients who are unaware of presence of cirrhosis. To the right, I'm showing you, depending on presence of obesity, that is BMI of 30 kg per meter square or below, which is non-obese. And you can see the risk is much higher in those who are obese, particularly for cirrhosis, also for at-risk MASH, as well as for MASLD in those with obesity. There's a clear connection between insulin resistance, type 2 diabetes, metabolic syndrome, obesity, and MASLD. Typically, what we see is that fat deposition in the liver occurs earlier, leading to hepatic insulin resistance, and then development of diabetes in future. But there are a lot of patients who have type 2 diabetes where we see coexistent hepatic steatosis. And together, this can lead to increased risk for cardiovascular disease. One particular pathogenic mechanism that is induced in fatty liver disease and MASLD is increased de novo lipogenesis. This can lead to atherogenic dyslipidemia and chronic inflammation, leading to increased risk for cardiovascular disease. There are other factors also associated with pathogenesis of MASLD and its progression, particularly related to dysbiosis, also activation of LPS-related toll-like receptors in the liver, leading to recruitment of macrophages, causing activation of stellate cell and fibrogenesis. We also notice that there are particular cytokines that are increased in the setting of NAFLD, such as interleukin-6, IL-1 beta, activation of inflammasome, and TNF-alpha. We also notice that the adiponectin, which is protective, those levels come down in our patients with MASH and advanced disease. With treatment, those levels can come back up. We also have noticed that there are particular genotypes or genetic risk associated with MASLD, such as PNPLA3, TN6SF2, as well as other genotypes. Here we're looking at multiple hit hypotheses related to progression of liver disease. Typically, our patients have fat deposition in the liver, leading to hepatic insulin resistance. Continuation of that, particularly in those who have excessive liver fat, and continuation of that leads to increased DNL, leading to lipotoxicity, along with decreased beta oxidation. This can lead to apoptosis, which is on the biopsies shown as balloon hepatocytes or Mallory-Denk bodies, leading to fibrogenesis and laying down of collagen, leading to progression to cirrhosis. There's also risk of hepatocellular carcinoma. Patients with MASH can also develop HCC without going through cirrhosis. This is really important, and pathogenetically, we don't really understand which patients with NASH could develop hepatocellular carcinoma without going through cirrhosis. There are several potential targets for treatment of MASH. I think understanding the molecular mechanisms behind them would be important. The key mechanisms that are involved in fatty liver disease progression include increased insulin resistance and increased hyperinsulinemia and hyperglycemia. Both hyperinsulinemia and hyperglycemia leads to activation of a transcription factor in the liver called SRBP1C. That activation leads to increased lipogenesis. This lipogenic drive is also seen as hypertriglyceridemia in our patients. And this is really important as a driver of disease progression and lipotoxicity. This can lead to mitochondrial dysfunction, leading to mitophagy, which can be corrected by various therapies, and we'll look at some of them today. There's also a component of chronic inflammation that is present and immune cell trafficking related in NAFLD progression. We also know the important role of gut microbiome leading to activation of hepatic stellate cells in the liver. There is a clear relationship between increased free fatty acid from periphery coming into the liver, leading to either deposition of those free fatty acids into the liver as triglyceride or export of these as VLDL, which is what we see as hypertriglyceridemia in many of our patients. Therapeutic targets that could improve these would be GLP-1 analogs that lead to improvement in body weight, leading to decreased glucose as well as decreased insulin, resulting in decreased traffic of free fatty acids coming into the liver, and therefore improvement in lipotoxicity. We also noticed that there are other therapies such as thyroid hormone beta receptor agonists that could also improve liver disease by increasing beta oxidation. Therapies such as ACC inhibitor, DGAT inhibitor, and others block de novo lipogenesis and improve liver disease. FGF21 analogs improve liver disease by activation of PPAR alpha and also decreasing free fatty acid influx in the liver and improving liver disease and ER stress and also hepatic fibrosis. Multiple mechanisms are now noted to improve liver disease related to steatohepatitis. Looking at GLP-1 action both in pancreas, liver, and gut. It reduces hepatic steatosis by modulating the insulin signaling pathway. It also reduces hepatic steatosis by enhancing the unfold protein response and promoting macroautophagy. Protects hepatocytes from fatty acid-related death by inhibiting dysfunctional ER stress response. It's really important that this interplay between pancreas, adipose tissue, as well as liver that leads to improvement in liver disease. The action of GLP-1 analogs are predominantly central, leading to decreased satiety and reduction in body weight, leading to improvement in liver disease. Now I'll pass it on to my co-chair, Dr. Ellen.
Thank you, Dr. Lumba. So we'll move forward towards another topic related to making informed management decisions in MASLD and MASH, and I'll specifically cover the non-invasive monitoring of disease progression. This is a list of risk factors for those who are at risk to progress. And by progression, we typically mean fibrosis towards cirrhosis and complications. And the risk factors include overweight status, presence of type 2 diabetes, metabolic syndrome, hypertension, elevated triglycerides or lipids in general. Intestinal microbiota plays a role as well. The more risk factors, the higher the risk, and 2 or more is where the cutoff, where the mark seems to increase significantly. Incidental finding of hepatic steatosis or abnormal aminotransferases, or advanced MASLD fibrosis score or fibrosis on biopsy. This is a list, a short list, kind of not the comprehensive of non-invasive tests, but the ones that are the most important and the most studied in this disease. And these tests review the non-invasive ones compared to the invasive one at the bottom, which is liver biopsy. So we'll go over a few of these tests, their benefits and their limitations. We'll start with FIB-4 or NAFLD fibrosis score, which are 2 blood biomarkers that have the benefits of being accurate and convenient and can be used in routine practice using clinically collected data for routine healthcare assessment. What they have as the most important benefit is an excellent negative predictive value, meaning that we can use them to rule out those who have advanced fibrosis. The limitations relate to accuracy mainly, and this accuracy decreases at the extreme of ages in younger than 35 and older than 65. They have poor positive predictive value, meaning that if the score is high, we're not quite sure that this truly means advanced fibrosis, but it does mean that we need to be worried about it and we need to do another test. The other part is that there's a large proportion of patients who have indeterminate scores in between the lower cutoff and the higher cutoff, which we will go further in details later. The other non-invasive test to mention is liver stiffness measurement with FibroScan or vibration-controlled transient elastography. The main benefit of this test is that it is a point-of-care test. It can be done in any clinical setting, including non-hepatology practices like primary care or endocrinology. There's no need for radiology or scheduling another appointment. and they have a high negative predictive value to exclude advanced fibrosis. The limitations are related to reliability or accuracy, which is impacted mainly by the body mass index and specifically by the waist circumference. The BMI cutoff where caution needs to be exercised is 30 kilograms per meter square. Anything else that can increase the liver stiffness, such as inflammation, with the surrogate being high ALT, cholestasis, congestion, such as a heart failure situation, non-fasting state where there's portal venous flow from the gut, and operator dependence are some other things to consider when we interpret that value. The other limitation is that it cannot predict MASH accurately. MR elastography is another form of elastography using magnetic resonance imaging, which is highly accurate, the highest accuracy for fibrosis estimation compared to the other non-invasive methods. And it can be used in those with a BMI that is higher. So it does not have any limitations related to waist circumference, hepatic steatosis, etc. The limitation is that it is not widely available. It needs to be scheduled in radiology, and it cannot predict MASH accurately. The invasive methods, the liver biopsy specifically, is the imperfect gold standard that we have. And we use most of the important criteria there, such as steatosis, ballooning, inflammation, and fibrosis to stage disease severity. The limitations are clear. It is time-consuming. Can be associated with complications such as pain or even bleeding. There could be sampling error because the disease is heterogeneous. There are cost implications, complications risk that I mentioned, and it is not appropriate or possible to apply this method to screen or stage the disease of every patient with MASLD. We'll go a bit in more detail into the FIB-4 index, or fibrosis 4, which was designed to predict advanced fibrosis in the liver, initially in hepatitis C concurring with HIV, but subsequently validated in MASLD. This score includes 4 components: age, ALT, AST, and platelet count. And the cutoffs that I mentioned earlier, and we need to remember, are 2. The lower cutoff is 1.3. Anyone with a score lower than 1.3 can be pretty accurately ruled out as having advanced fibrosis. You can see the sensitivity and specificity parameters listed there. The higher cutoff is 2.67, and this cutoff is used to predict advanced fibrosis with a lower sensitivity of 33%. So remember, we talked about that low positive predictive value of this higher cutoff. About half of the patients in most studies are in that gray zone or indeterminate, where we don't really know where to place them. So we need another method of non-invasive estimation. So it is not perfect, but it is accessible by any non-hepatology provider, and it is the best that we can do currently in clinical practice. The ELF score is another blood-based non-invasive test, which is a proprietary test that delivers information on liver fibrosis severity. And this algorithm incorporates 3 common serum biomarkers, and these are hyaluronic acid, aminoterminal propeptide of type 3 procollagen, and tissue inhibitor of metalloproteinase 1. So as you can see, these have to be ordered and have to be measured and tested and resulted as a number, which is the ELF score. The cutoffs are as the ones that you see listed here. A lower cutoff of 7.7 can be used to rule out fibrosis with pretty good sensitivity, but a lower specificity. A score of 9.8 is used to predict fibrosis, and a score of 11.3 is used to predict cirrhosis. And you can see here distribution of these scores based on the 4 fibrosis stage. 9.8 or higher is what we use to estimate advanced fibrosis. There are then combinations of elastography and blood biomarkers, and this is a study that Dr. Lumba performed where he compared the most common ones that most commonly used, and these are MEFIB, MAST, and FAST. And you can see here on the bottom right panel what these models include. So MAEFIB is a combination of MRE and FIB4. The numbers that are used to rule in fibrosis are 3.3 kilopascals by liver stiffness measurement and a FIB4 higher than 1.6. MAST includes MRI-PDFF, liver stiffness by MRE, and the AST value. You can see the two cutoffs for ruling in and ruling out advanced fibrosis. And FAST is derived by FibroScan and includes the continuous attenuation parameter, or the measure of steatosis, the liver stiffness measurement, and AST, with the two cutoffs that are listed there. So in this very large study of over 500 patients with biopsy-proven MASLD and disease severity estimation from the United States and Japan, these three biomarkers were compared, with the endpoints being the detection of significant fibrosis or at-risk MASH, which is NAS above 4 or higher, and fibrosis stage 2 or higher. These are the results of this study, which show that MAEFIB is superior to MAST or FAST for the detection of significant fibrosis on the panel on the left, and for the detection of at-risk MASH in the panel on the right. And you can see the area under the curves listed here in the figure. MAEFIB has a high positive predictive value of 95% and negative predictive value of 90% to detect significant fibrosis, and may be used as a two-step strategy. So the most recent practice guidances from AASLD are listed here, and this puts together these non-invasive tests into an algorithm when we have clinical suspicion for fatty liver disease. So the primary risk assessment is done by FIB4. Remember that lower cutoff of 1.3. Anyone with a score lower than that does not have advanced fibrosis and needs to be reassessed periodically with FIB4 every 1 to 2 years if they have diabetes or 2 or more metabolic risk factors, every 2 to 3 years if none of these are present. If FIB4 is 1.3 or higher, then they need a secondary risk assessment, such as FibroScan or ELF, and these two cutoffs are recommended here for further evaluation to the liver clinic, so a stiffness of 12 kPa or an ELF of 9.8. If these are present, they need to be referred for further evaluation, or if the FIB4 is 2.67 or higher, they can be directly referred to hepatology. There are primary and secondary risk assessments depending on what has been done before, additional stratification for clarification with MR elastography or corrected T1. If the disease is ruled out, they are back to primary care practitioners for follow-up. If they have intermediate or high risk, then we either consider liver biopsy if we need to further stage, and based on the staging, either by biopsy or non-invasive tests, we either reassess every 2 to 3 years for early stage or annually for stage 2 to 3. And this is the category where pharmacotherapy should be considered because these patients are at the highest risk of progression to cirrhosis. For those with cirrhosis suspected or proven, we need to implement cirrhosis-based management, which we will not go further in here, but essentially means monitoring for liver cancer, esophageal varices, and other complications. And with this, I'll pass it on to Dr. Lumba, back to pharmacologic agents.
Thank you. Now, this is looking at the AGA risk-based guidelines, so patients who are low risk, intermediate, or high risk. And depending on where the patient sits, I think you can see the most important thing would be lifestyle interventions that are relevant across the board. A majority of our patients are overweight and obese, so weight loss is recommended in those individuals. Now, in those who are low risk, pharmacotherapy for MASH is not recommended. Those are intermediate or high risk, pharmacotherapy for MASH is recommended. CVD risk reduction is recommended across the board. Majority of our patients have hyperlipidemia, so they may be candidates for statin use. Now, diabetes care is also really important because uncontrolled type 2 diabetes can lead to progression of liver disease and progression of steatohepatitis. So for co-management of patients who have type 2 diabetes, what are the therapies that are recommended in patients who also have MASH. And this AGA risk-based guidance recommends you could consider pioglitazone, you could consider GLP-1 analogs, and you could consider other therapies that may be beneficial in the setting of type 2 diabetes. Now, those patients who also have obesity and type 2 diabetes, we are currently seeing more and more GLP-1 analog use in those patients in improving their diabetes as well as obesity and other cardiometabolic renal profile. These are the goals for treatment. Short-term goals are to reduce liver fibrosis and prevent progression to cirrhosis. Long-term goals for treatment of MASH-related therapy is to improve clinical outcome by reducing the risk of hepatic decompensation, but also reduce the risk for all-cause mortality, which is really related to cardiovascular disease and cardiovascular mortality in our patients with NASH. If you compare various guidelines, ASLD, AGA, EASL, ESED, ESO, and NICE, you can see that there are important differences between many of these societies or organizations. I think the most up-to-date currently is the ASLD 2023 practice guidance. And where we are considering use of GLP-1 analogs in the setting of obesity and type 2 diabetes in patients who also have MASLD for treatment of type 2 diabetes and obesity-related complications. Semaglutide or GLP-1 analogs are not recommended for treatment for MASH-related fibrosis currently because trials are underway. Currently, resmetirom is the only FDA-approved pharmacologic therapy for treatment of MASH-related fibrosis in patients who have stage 2 or stage 3 fibrosis. For patients with cirrhosis, no pharmacotherapy is indicated currently. For low-risk patients, those who have a FIB4 below 1.3 or have a liver stiffness below 8 kilopascal, lifestyle modifications are recommended along with control of cardiovascular risk factors, as well as if they have type 2 diabetes, management of type 2 diabetes. Similarly, for intermediate risk patients, and they might require referral to a hepatologist for further evaluation with a liver stiffness assessment. High-risk patients may be considered for treatment with 800 units of vitamin E in those who do not have type 2 diabetes. This is based upon PIVENS trial data that was published several years ago through NASH CRN. There is data on pioglitazone as well, but it's not favored by clinicians given weight gain in patients with steatohepatitis. Thiazolidinediones have been used, but there are also side effects associated with those therapies. Again, none of these therapies are recommended in the setting of cirrhosis. These are some of the agents that are currently in phase 3 clinical development with resmetirom that has had a Subpart H approval, a conditional approval for treatment of NASH for stage 2 or stage 3 fibrosis. Semaglutide, which is a GLP-1 analog, is currently being assessed in ASCENT trial for improvement in resolution of NASH without worsening of fibrosis or improvement in liver fibrosis by one stage and no worsening of steatohepatitis, as well as time to liver-related and clinical events. This trial is underway. Lanifibranor is a pan-PPAR agonist, and that NATIVE-3 trial is also underway, looking at resolution of MASH and improvement of fibrosis as an endpoint. Efruxifermin and pegozafermin are two FGF21 analogs that are also in clinical development. Synchrony is a trial that's underway with efruxifermin, looking at resolution of MASH and one-stage improvement in fibrosis in those who have stage 2 or stage 3 fibrosis. And pegozafermin with ENLIGHTEN-Fibrosis program, also looking at fibrosis improvement without worsening of MASH or MASH resolution without worsening of fibrosis. This is the data related to MAESTRO-NASH phase 3 Subpart H or 1-year treatment assessment. To the left, I'm showing you NASH resolution with no worsening of fibrosis with approximately 30% patient on resmetirom 100 milligram compared to 26% on 80, versus 9.7 on placebo. Resmetirom also showed improvement in fibrosis with about 26% on 100 milligram, 24% on 80 milligram, and 14% on placebo. This drug also led to a reduction in LDL cholesterol, as shown here. Now looking at semaglutide data, this is a GLP-1 analog that was shown in patients with NASH stage 2 or 3 fibrosis over 72 weeks to significantly improve MASH resolution. To the left, I'm showing you 3 different doses of semaglutide versus placebo in orange at 17% MASH resolution versus 59% with the highest dose, which was semaglutide of 0.4 milligram daily sub-Q. Currently in the ESSENCE trial, we're using 2.4 milligram sub-Q weekly dose that will be similar to the semaglutide 0.4 milligram daily in terms of its expectation. To the right, I'm showing you data on numerically higher fibrosis improvement, but was not statistically significant compared to placebo. This may be related to the sample size. In the ESSENCE trial, we hope to assess both of these endpoints rigorously at 72 weeks of treatment. The trial will then continue for long-term clinical outcomes. Semaglutide treatment is associated with higher rates of GI side effects, such as nausea, constipation, and vomiting than placebo. These are some of the side effect profile related to semaglutide in the phase 2b trial. You can see generally it is GI side effects that are associated with semaglutide use. Particularly, they happen in the first 16 to 24 weeks. What we do is we generally go at a lower dose and slowly escalate the dose and take to full dose over 16 to 20 weeks of treatment. This is looking at lanifibranor data, which is a pan-PPAR agonist. This is 24 weeks of treatment or 6 months of treatment with lanifibranor. To the left, I'm showing you a reduction in 2 points in SAF activity score, which is similar to the NAFLD activity score without worsening of fibrosis, which was significant for the highest dose of lanifibranor, 1,200 milligram orally daily versus placebo. Secondary endpoint of one-stage improvement in fibrosis in the middle, 42% on the 1,200 milligram versus 24% on placebo. And to the right, NASH resolution, which had a dose-dependent response, and both the doses had a significant improvement compared to placebo. This is also in phase 3 program now. These are the side effects associated with lanifibranor. Again, some GI side effects and weight gain, as we previously discussed. This is looking at efruxifermin, which is a pegylated form of FGF21. To the left, I'm showing you fibrosis improvement at 6 months by one stage with no worsening of NASH, 41% on efruxifermin 50 milligram dose sub-Q versus 20% on placebo. NASH resolution was significant at 76% with the 50 milligram dose versus 47% at 28 milligram versus 15% on placebo. Fibrosis improvement and NASH resolution at week 24 was seen about 41% of patients with 50 milligram dose and 29% on the 28 milligram versus 5% on placebo. These are some of the side effects associated with efruxifermin. Again, GI side effects are common in patients treated with FGF21 across the board. We also noticed some injection site erythema and increased appetite as opposed to decreased appetite that is typically seen with GLP-1 analogs. There's some injection site bruising as well, and minor headache. This is looking at pegozafermin, which is a glycopegylated form of FGF21. To the left, I'm showing you fibrosis improvement by one stage without worsening of fibrosis, where pegozafermin 44 milligram sub-Q every 2 weeks had a 27% response compared to 7% on placebo. To the right, I'm showing you NASH resolution compared to placebo. All the doses of pegozafermin were significant compared to placebo. The highest dose is looking at pegozafermin of 44 milligram every 2 weeks. These are side effects associated with pegozafermin. Again, GI side effects were common. There's increased appetite noted with FGF21 as a class, and we also noticed some injection site reaction and headaches. So the key idea, as Dr. Allen previously pointed out, we are looking for patients who would be candidates for therapy, and these patients would be who have significant disease that is NASH stage 2 or 3 fibrosis. We want to look at clinical efficacy for both NASH resolution as well as one-stage improvement in fibrosis to identify which therapies would be effective, and also look at safety of the medications in the intended population that we plan on treating. We also want to look at cardiovascular risk benefits related to the therapy that we are using, and avoid patients who have higher alcohol consumption, because that may be leading to progressive liver disease, and identify those patients and tackle that up front by asking them to reduce their alcohol consumption. We also assess how best to report liver biopsy results in these phase 3 as well as phase 2b trial, and now there's an emerging theme in terms of how those could be rigorously assessed. And majority of protocols are now using that modality to have 2 or 3 pathologists looking at histology data with either a mode read or a consensus read. Now we're going to look at optimal management of MASLD, experts versus AI. So this is the question. A 51-year-old man has obstructive sleep apnea and type 2 diabetes, hemoglobin A1C is 9, BMI is 32, AST is 41, ALT 50, platelet count of 200,000. No history of liver disease or excessive alcohol consumption. What would be the best next step for this patient for suspected MASLD or MASH? Number 1, FIB4. Number 2, NAFLD fibrosis score. Number 3, FibroScan. Number 4, MRE, or not sure. So let's ask AI, and we type in the question to AI and see what the response is. Okay. So, well, AI is saying they want to jump to and get a FibroScan. What do you think about that, Alina? Is AI right or wrong here?
Well, it looks like if we were to ask what's the next step that we need to implement to evaluate their risk based on the guidelines and based on the fact that we can't do this for the entire population who has these comorbidities, I think AI is wrong.
Yeah, I think AI jumped the gun here. And
yes.
So let's see if we want to give it an opportunity to correct itself. Hey, AI, shouldn't FIB4 be assessed first? Let's see what it's thinking. Okay, well, you are correct. My apologies for the oversight. Very polite. So looks like I think we would want to do a FIB4. So let's ask, what is his FIB4 score? I know you've already calculated it here. So FIB4, as Alina mentioned, is age, ALT, AST, and platelet count. And FIB4 for this patient is 1.48. So this patient is right in the middle, right?
Right, and AI knows how to calculate it, which is good.
Yeah.
So as long as you direct it to the question that it's really likely to be answered correctly, it is right. And yes, this patient is right in that in gray zone, that indeterminate stage of between the lower and the higher cutoff. So I guess we should ask AI what to do next.
Given a FIB4 of 1.48, does this patient have MASLD or MASH? So does this patient have MASLD or MASH AI? What do you think? Alina,
Yes,
what do you think?
so I think, it says a low risk of advanced fibrosis, not sufficient, which is good. They recognize risk factors and they recommend further assessments, such as imaging study, transient elastography, and or biopsy because of the clinical profile. So I think they got this one right. Gray zone needs further testing, as we mentioned before.
Yeah, so this patient is right in the middle with FIB4 of 1.48. So the next step would be based upon our ASLD algorithm to try to get a VCT or MR elastography, but I think VCT would be the next best step. You could consider ELF testing as well, but I think in this particular setting, let's see what options do we have. What additional testing would you order next? Number 1, MASLD fibrosis score. Number 2, FibroScan. Number 3, MR elastography. Number 4, liver biopsy. Number 5, not sure. So what test should be done next, AI? Okay, so AI also picked correctly this time, wants a transient elastography or FibroScan, and wants to see what we find based upon transient elastography. Depending on the machine you have, you could potentially get both CAP, which is controlled attenuation parameter, to look at fat content in the liver, and also look at the liver stiffness at the same time. So let's see what we get next. If transient elastography FibroScan shows a CAP of 289 decibel per minute, and liver stiffness is 8 kilopascal, would you recommend pharmacotherapy at this time for this patient? Number 1, not warranted. Number 2, is warranted for this patient. Number 3, I need more information. 4, not sure. So let's ask AI, what is AI thinking? So I think this is good. AI says CAP of 289 decibel per minute indicates hepatic steatosis, which is true based upon some of our studies. It corresponds to a PDFF of 5% or higher, which is liver fat content. And liver stiffness of 8 kilopascal is looking at, high likelihood of minimal mild fibrosis. And then, so you wouldn't be thinking about treating the liver fibrosis because we don't think it's to stage 2 or stage 3 based upon the information that we have. So you would want to optimize their metabolic health and think about treatment of their obesity and type 2 diabetes with the best possible modalities that are available. Lena, back to you.
So we'll conclude. Maybe the 5 takeaway points would be that MASLD and MASH are metabolic diseases, often co-occurring with type 2 diabetes, overweight, obesity, and metabolic syndrome. Second, MASH needs to be treated, as well as the key metabolic abnormalities such as obesity, type 2 diabetes, and cardiovascular risk. There are new metabolic targets associated with liver disease improvement in patients with MASH. Several new promising therapies are on the horizon, as you saw several in phase 3 trials. Resmetirom was recently approved for the treatment of adults with MASH with moderate to advanced liver fibrosis. And lastly, patients who are at risk for MASH can be identified in routine clinical practice by sequential non-invasive tests.
Great, excellent. So we have a bunch of questions here from audience that I'm going to pose, and we can discuss some of those. And if you have any questions, please let us know. We'll be happy to entertain them as well. Question 1, what is a non-invasive test that could be used for children with fatty liver?
Good question. The pediatric population is really a special type of population because most of these tests that we just talked about don't really apply or are validated and shown to be accurate in pediatric population. FIB4, which is first line in adults, is not very accurate in pediatrics because of the age inclusion in the marker. So it will potentially miss a lot of these patients who are at risk. So in this population, most of the time we need to go to elastography. The studies there are also very limited, but they are promising. It looks like FibroScan and MR elastography are pretty accurate from the small sample sizes that we've seen. ELF, I'm not sure there's a lot of data in pediatrics, and I don't think currently is used. So essentially for kids is elastography.
Yeah, I agree. Both VCT and in our setting, MR elastography provides pretty good assessment for liver disease in pediatric NAFL. Let's take a look at the next question. Are GLP-1 analogs awaiting FDA approval?
Yes, as you mentioned, I don't know if you want to take this one, Rohit, because
Yeah,
you covered the treatments.
Essence trial is underway, and we're looking at role of semaglutide for treatment of NASH, 72 weeks assessment, and then continuation for long-term clinical outcome. And I think we will have those results in the next several months. So they're definitely in phase 3 currently. Next question. What is the importance of vitamin E in treating MASH?
As you highlighted in the slides, vitamin E has been studied. It was probably one of the first major trial for NASH at that time in 2010. It does have some impact on improvement of steatohepatitis, steatosis, a little bit on fibrosis, but not significant compared to placebo. So it's gained some favor before. We now have more robust liver-directed therapies. So I currently personally don't use it much because the new wave of therapeutics, which includes drugs that can affect the cardiometabolic profile, including the weight and diabetes, I rely less and less on vitamin E.
I use vitamin E in patients who have NASH and who have early fibrosis or no fibrosis, because that's what was shown in Piven's trial. In those who have stage 2 or higher fibrosis, I tend to use other medications that have higher efficacy and higher level of evidence. There's a question, this patient has a BMI of 32. I thought FibroScan was not a good tool, may want to consider MR elastography. So what do you think, Alina, on that?
Well, you've done the studies that looked at the VCTE versus MRE based on BMI, and based on those trials, I was more convinced to use that BMI of 30. So whoever put this question is correct based on the data. That's what I use in clinical practice as well. And we have to remember that BMI is a number, but we have to put it in perspective along with the degree of central adiposity too. So a BMI of 32 in a pear-shaped person who needs assessment, but maybe we don't have MRE, we can rely on a FibroScan. If significant central adiposity, I would favor an MR elastography. So
yeah, I think you could definitely consider it. Just to answer, based upon our study, we have a cut point at 35 or higher. So basically, we put it 32 for that reason. I think it's reasonable to get a FibroScan. But I agree that if you really wanted highly accurate information, you could go for MR elastography. Let's take a look. It seems like there are two treatment goals, decrease steatosis and prevent or reverse fibrosis. Also, many of the side effects of efruxifermin seem opposite to GLP-1 receptor analogs. Is there any utility in combination treatment, both for increased efficacy and for optimization of side effects? So I would say there are two treatment goals. Treatment goal 1 is to reverse NASH, and treatment goal 2 is to reverse fibrosis. And then talking about FGF21 with GLP-1 analog, there actually is a trial that is currently underway, and we will have probably results next year to look at combination of GLP-1 analogs with FGF21 in patients who had NASH stage 2 to stage 4 fibrosis. So we will have a good idea whether this combination is better than monotherapy alone. So we would have additional information. There was a pilot study done with patients who had NASH stage 2 or 3 fibrosis who were already on a GLP-1 analog, and then they added efruxifermin or placebo and noted that you could see improvements with addition of efruxifermin. We also have data with pegozafermin that those who were on GLP still had benefits of pegozafermin on top of their background GLP. The issues with some of those trials is the dose of GLP and whether you have the most potent GLP-1 analog in those studies. But I think we will have data on the combination approach. Let's take one more question. How is an NIT biomarker used to monitor response to therapy?
that is the really important question of the field nowadays, because we truly don't have data based on that is robust based on the current FDA-approved drug. But we do have other studies that have been consistent in showing a decrease that correlates with improvement in histology. And the other, that's one, so we can extrapolate from those studies. The second piece is the time aspect of it. When do we want to assess improvement? in response to therapy. Because if we want to assess improvement in fibrosis, we can't expect that to happen fast. So I guess my answer, if I were to summarize, would be if we want an answer fast-ish, let's say 6 to 12 months, it's going to be hard to ask a liver stiffness measurement or a blood test to really show significant improvement. So then I would use something like MRI-PDFF, for example, which again in Dr. Lumba's studies, in several actually, it has been consistently associated with resolution of NASH or MASH, or at least improvement. That is histologically important. When we have the luxury of time over many, many years, we will probably use things like liver stiffness measurement, maybe ELF to answer that question. But for now, for maybe a 12-month response, that's the one I would say we use as the best evaluator.
Yeah. I think if you look at the therapies that are in phase 3 that we discussed, so resmetirom, GLP-1 analog, FGF21, both, as well as lenifibranor, although we don't have data on lenifibranor. But I think these predictors will still work with lenifibranor also. But we have data on all of these 4, resmetirom, semaglutide, efruxifermin, and pegozafermin, that MRI-PDFF would predict NASH resolution pretty significantly, 30% response. We also have data of combination of MRI-PDFF plus ALT, something called as MASH resolution index, that could predict treatment response. Just this afternoon, I presented data on resmetirom, predictors of response to treatment, and in those also PDFF improvement were predictive of response. Previously, at last EASL, Vincent Wong had presented data on semaglutide, that FAST score that Alina talked about, which is a combination of CAP, liver stiffness, and AST. A 0.2 decrease in FAST was associated with higher odds of NASH resolution. So with that, we would like to close this program. I would like to thank Dr. Ellen for this wonderful discussion, and to all of you for being here and for your participation.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/RNX860. This activity is supported by an educational grant from Novo Nordisk Incorporated.